Morning, everyone around the world. We are starting today with our webinar. I'm very excited that this is our first implementation webinar. We have, as we know, the engagement of the private sector and private practitioners is a big topic in TB control, and we have a roadmap on how to do it. And still we have many questions from around the world on how to actually do it. So we're excited to actually to have a more specific series where we are looking at concrete examples from on-the-ground experiences. And today I'm really pleased that we have Hamidah Hussain and Imran Zafar, who are going to be talking to us about many years of experiences that they have on actually engaging the private sector. So what we are doing, we're having a 1 hour. We're recording this session. This will be available on our website afterwards for anyone who wants to view it. We have a chat function on the site where you can ask any questions that you want during the webinar. If you have questions during the presentations, feel free to use the chat function. I will all the if there's difficult of us and so that we have a discussion with everyone. I'm pleased to start with Hamidah Hussain. She works as a program director at IRD. She has many years of experience in public health in delivering health services and expertise also in epidemiology research. She's prepared a presentation for us, so we're going to switch to her presentation. I'm pleased to give the word to Hamidah.
Hello, everyone. I hope you can see the slide. If you can, please let Petra know.
Yes, I can see the slide.
Excellent. All right. So I'm going to talk about Zero TB Karachi and efforts that have gone in and what are the early lessons that we have learned from the efforts of search, treat, and prevent at scale in the city of Karachi. At various points, I may make references to other cities that have done something similar with IRD as a partner. But primarily the presentation will focus on Karachi. So before I delve into the presentation, I just want to introduce IRD. IRD stands for Interactive Research and Development. We are a group that is based out of Singapore. We have country offices in approximately 9 to 10 countries in the world and primarily work on infectious diseases, neglected tropical diseases, maternal and child healthcare programs, non-communicable diseases, as well as global health surgery. In addition, we are, in addition to the countries that we work in with ground presence, there are a number of other countries, over 15 in fact, where we have supported multiple different programs as a partner. And IRD is also a partner and a founding member of an initiative called Zero TB Initiative. This initiative is essentially there to create TB eliminated areas, be it cities, be it districts, or whatever locality we are working in. One of the basic principles of this is that we must have a very strong local partnership and ownership of the city or the district itself. Zero TB implements evidence-based search, treat, and prevent approaches, and they could be in various forms and ways in which these principles are implemented. In addition to IRD, Stop TB Partnership, Center for Global Health Delivery, Dubai, Harvard Medical School, as well as Advanced Access and Delivery are also partnered to this initiative. There are many countries and cities around the world that have actually signed up, and you can actually get this information from their website of how they function and other very many resources as well. So now going into Zero TB initiative for Pakistan. Our group started working with an implementing partner, the Indus Health Network, in the city of Karachi, primarily in the industrial zone in Karachi, since 2011. And these initial efforts were all based on the active case finding approaches and looking at both the public as well as the private sector to conduct active case finding approaches. These studies were all funded through TB Reach, multiple different waves, where we explored how to work with with both the public and the private sector. In 2016 and 2017, the Global Fund chose Indus Health Network to be one of the principal recipient of their TB and malaria initiatives in Pakistan. And they, where IRD was the technical partner. And with that support from Global Fund, we embarked on what we now call Zero TB Karachi, the first city, as well as 32 districts in Pakistan. In 2018 to 2020, we had another renewal of the grant amount. And then we included, in addition to Karachi, now Peshawar and Quetta, as well as Zero TB cities. So essentially, what does Zero TB really mean? Essentially, it means that wherever we worked as a Zero TB, or whichever city was declared as a Zero TB, it had the search, the treat, and the prevent aspects of it. So if you look at this map of Pakistan, the southern parts of Pakistan, right at the bottom of your map, you see Karachi, a bubble out of Karachi. And if I want to focus on that, you will see that there are active case finding sites. These are both public and the private sector sites. There are sites where we are doing extensive active case finding for child TB. Then there are sites where we are providing the preventive treatment. The private sector is engaged primarily through our partners, CHS, which is Community Health Solutions. And Imran later on will talk in depth about those sites, but there are about 31 sites in and around Karachi. We are also involved in providing the drug-resistant TB treatment. So there are sites which are managed by the Indus Hospital and are called PMDT sites. These all efforts of active case finding are supported by chest x-ray vans, mobile chest x-ray vans, additions of gene expert machines, addition of human resources, and many, many more things. So I will go into the depths of each of these and to show what has gone in. Similar work has been done in Peshawar and in Quetta. So in 3 Zero TB cities and 32 districts, we have over 1,200 staff members which have been recruited, and they are working with the government sector as well as in the private sector. Over 3 million people have been screened on verbal symptom screen for tuberculosis. 55 mobile X-ray vans and 70 fixed X-rays have been deployed. 1.5 million chest X-rays have been done, and over 61,000 TB patients have been notified to the National Tuberculosis Control Program. In addition to that, at each of these sites, additional gene experts, I didn't mention that in this over here, it's not mentioned, but additional gene expert machines were deployed to support the increased demand, as well as UVG lights were put in for infection control. Before we embarked on this, how did we actually started working? So excruciating long planning cycles went in to create what we call the search, treat, prevent chakra. And chakra just means a circle. And Zero TB initiative asks every city or every district to kind of, create this for themselves and to understand where and how they can prevent, they can do the activities of search, treat, and prevent. So for Karachi, when we started, if you look in the search box, you will find multiple different activities of how the plan was done. So to do active screening, to ensure that X-rays and the gene expert testing was provided free of charge. Other diagnostic tests were provided free of charge. How to build the capacity. These were all ways and means to start acting on that, and how to then engage the community. So again, this kind of a thing needs to happen for every city that embarks on extensive and scale up of Zero TB initiative. As we were planning, I still remember as we were planning, one of our colleagues came up and said that if you do not work in the public sector and you do not strengthen the public sector, you will never be able to fully get rid of TB, because they are the primary care provider for tuberculosis. So a lot of our work has actually gone into public health facilities, even though we were principally a private sector group, but we worked with the public sector with support of our National Tuberculosis Control Program in enhancing the work that was being done at those public health facilities. In addition, of course, the private sector, both the for-profit and not-for-profit private sector was engaged, and of course the community which they serve were also engaged in this effort. At each of these private sector site, what did we actually do? Private or public sector site, sorry. So we screened people, and how the people were screened is both by symptom screen as well as chest x-rays. And they were, we approached very large outpatient clinics of large hospitals. These outpatient clinics may see up to 500 to 600 and sometimes up to 1,000 patients a day. So these are really large tertiary care hospitals. Those outpatient clinics, we signed agreements with each of these hospitals and provided resources in terms of human resource as well as X-ray, mobile X-rays, gene experts to each of these hospitals to be able to screen people. So anybody who had cough for more than 2 weeks was then asked to go through an X-ray system. And this were anybody and everybody that was coming in for to seek care at the hospitals. These were not people who were just there for symptoms of TB. This could be at an OBGYN ward. This could be at a fever clinic. This could be at an emergency area. So anybody who had cough for more than 2 weeks were screened with the chest X-ray, and this a digital chest X-ray was put in place with CAD4 system. Anybody who had a score of less than 70 was deemed not possibly TB and was asked to see a doctor for resolution of their symptoms, and also were counseled that if they have any chest symptoms, they should then seek further care. Anybody who had a score of more than 70 and was able to produce the sputum was tested through Gene Expert. If the person tested positive for tuberculosis, treatment was commenced immediately. If the person was unable to produce sputum or had an expert negative but still had cough for more than 2 weeks, they were then evaluated by a physician who then prescribed either further testing or decided that this may not be a tuberculosis case. Similar camps, similar process was followed at the community camps. So both at the outpatient medical centers as well as community, this kind of active screening went on. In the community and even at the house outpatient, I mentioned we had mobile X-ray vans. So this is pictures of those mobile X-ray vans. The top picture was actually taken at the inauguration or the launch of Zero TB Karachi. The building that you see is actually the mausoleum of the founder of Pakistan, Muhammad Ali Jinnah, who actually passed away of tuberculosis 1 year after Pakistan was founded. So that is where the launch of Zero TB Karachi was initiated. Each of these vans are actually branded, and you can see the brand, which is written in Urdu. And for those of you who do not understand Urdu, it says "Aao TB Mitao." "Aao TB Mitao," literal translation is "Come wipe out TB." There is also a prominent photograph that you see of a person. He is one of a cricket player. He's a sports person and really beloved in Pakistan. And he provided his time and energy free of cost for this effort. So he is the brand ambassador for our TB Mitao campaign. And each of these vans have a digital X-ray. The pictures that you see at the bottom. The first one, an X-ray technician is present who manages the machine. As soon as the X-ray is done, it is uploaded into a digital cloud system where it is read. And if required, they can also be printed, as you see in the last picture. The person is holding his X-ray. A patient is holding his X-ray. These are some other photographs of the vans at work, mobile X-ray vans at work. So the first one picture that you see is at a rural Indus Hospital site where the X-ray van is supporting the health facility, which did not have capacity to conduct all the X-rays. The pictures underneath, you see a line of ladies in the Karachi. So multiple different vans go into the community. They create these community camps and X-ray everybody who shows up in that. The vans also go into the rural areas, not only in the urban areas, but also in the rural areas, as well as in the snowy Himalayan communities. So essentially, these vans have traveled throughout Pakistan. And when they do that, they actually get press coverage. So you see a photograph with a person in the camera. So that was actually free TV coverage that the van received and the camp received, which really helps in spreading the word and convincing people to come for chest X-ray and screening for tuberculosis. What has the screening done? So I mentioned that our work started in 2011 through TB Reach grants. And if you see from 2010 onwards, you see an increase in the number of cases. But in 2016, as we embarked on the scale up through the Global Fund support, you see that the number of cases really jumped. So from a background reporting numbers of 15,000, we've been able to bring it up to 25,000 patients that have been reported in the city of Karachi. At each of these camps, I mentioned that they were camps at the large, these X-rays were done at the large hospital outpatient clinics, or they were done in a camp setting, or they were targeted to high-risk populations. And we have done some analyses of what it takes to find one patient with tuberculosis. So we found that the large hospital outpatient clinics, we have the best chances of finding TB patients. And if you screen 85 people, you will find one person with TB with an X-ray yield of 1.2%. Essentially, it means that these are low-hanging fruit. People are already ill and they are coming into hospital to seek care, but for whatever reason, they weren't being identified earlier. And now with the symptom screen and the chest X-ray, a larger number of them were identified with tuberculosis. Similarly, community camps, obviously, we all know that they will have lower yield because these are primarily people who may not have symptoms. Or if they have symptoms, they are probably in the early phases. So they haven't really come in touch with the health facilities as yet. Similarly, prisons and factories are considered high risk, but in Pakistan or in Karachi, what we found that factories were not really a place where we found too much TB. We also conducted screening among household contacts, and I will come to that a little later. But again, about 103 people were screened to find one person with tuberculosis. We have given, or our group has given special emphasis to childhood TB screening. It's hard to diagnose TB in children because they do not provide, they cannot have, the sputum is hard to come by, especially in younger children. So what we did is in the large outpatient clinics, we recruited nurses who actually screened all the children that were coming into the pediatric OPDs for screening, and then they were flagged to the physicians for further screening if there was any presumptive found. So what we see is that in this, about close to 700,000 children have been screened since the initiation of the Zero TB initiative. Of these, about 6.5% have been presumptive of all those that were screened. And TB was diagnosed in a fairly high percentage of those that were presumptive. All right. I mentioned that we did household screening. So how did we do household screening? So essentially, as soon as an index TB patient was identified, household contacts were enumerated with the help of health workers. They all went through symptom screen and were counseled to come to the facility for a chest x-ray. If they couldn't come to the health facility, and if we had enough numbers, a mobile camp was initiated just to do household contact screening. So at the clinic, the contacts were evaluated specifically by X-ray and an expert if they could produce the sputum. If anybody was found with the TB disease, they were immediately connected to the treatment arm and they were initiated on treatment. If no disease was found and they were completely free of tuberculosis, then they were offered preventive treatment. And since 2016 till January 2020, we see that about 16,000 people have been initiated on preventive treatment, be it through INH or with 3HP. In Pakistan, any children under 2 is given INH, and anybody over is given 3HP, especially in the facilities that are supported through Indus Health Network. So over a period of time, we have given preventive treatment to 16,000 people. And you can see the care cascade of those that 65% of those we have an outcome available. 71% have completed the treatment. There were obvious refusals. 8% of the people refused treatment after they started a preventive treatment. 20% did not complete treatment, and primarily these are people who were started on INH rather than on 3HP. We see a higher completion rates with 3HP than with INH. There were less than 1% where the doctors either stopped the preventive treatment due to adverse events or the person relocated and we couldn't support them anymore. And of the 16,000 that we have given preventive treatment, 18 were diagnosed with TB, 18 patients, so it's 0.17%. 35% of the people are still on treatment at this point as we speak. So we see about a 71% completion rate, which is fairly good. And as we learn more how to help people complete preventive treatment, more and more people have been completing the treatment. I want to just bring you to this study. You guys might have been shared this particular paper. This paper was published in 2013 by David Dowdy. It was based on our work from 2011 to 2012 of active case finding, whereby modeling showed that if active case finding is sustained in an area, it would bring down the incidence of tuberculosis for that particular area. And if it is done in a targeted fashion, then 25% reduction is possible. So in the area where we are primarily located, where Indus Hospital is primarily located, and we have had sustained active case finding for a number of years, we see actually a drop of 20% notification. And this is one town in Karachi. This is does not reflect the entire Karachi population, but one particular town in Karachi where the activities have been sustained, where we have had active case finding for adults, for children, and preventive treatment for adults and children, as well as all the support that has gone into that town. So we do see a drop in the incidence. My last couple of slides, I just want to bring to you that when we see a TB patient, we shouldn't treat a disease, but we should treat the person as a whole. So at some centers where we were working, what we instituted was an integrated practice units, which actually included screening for diabetes and depression for the patients who were suffering from TB. So essentially, any patient of TB was screened for anxiety and depression. They were supported through counseling for TB adherence and also for their anxiety and depression. They were also screened for diabetes, and they were provided with diabetes medication as required. What we saw was that 92% of TB, 92% of the patients who completed the mental health intervention also completed TB treatment, as opposed to 75% of those who did not complete the mental health intervention. So there, we can bring up our treatment success rate and treatment completion rates a fair amount if we actually help patients with their mental health aspects of tuberculosis and their other challenges. This slide shows that to do this at scale, just word of mouth is perhaps not sufficient. We do have to have an extensive communication campaign. So the program actually invested in making television ads, which were focused, one, on symptomatology, which was, everybody was informed that if you have cough for 2 weeks, please come and get tested. These were also focused on young women who are stigmatized, and older people who cannot access healthcare because they are limited to their home, and how to support them. In addition to that, we have a program called Kiran Sitara, which means ray and stars. Kiran means ray, and Sitara means star. So star rays. These are essentially young girls in secondary school system who are trained on youth leadership, and then they are also instructed on symptom screening in their neighborhoods. And what they do is 10 houses on the left and 10 houses on the right, they actually go ahead and screen everybody in their neighborhoods for tuberculosis. And with their support, I mean, so far up to 10,000 young girls have been trained, and they have been performing exceedingly beautiful. So to screen everybody for tuberculosis. The last slide is actually to acknowledge everybody, all the partners and people that have worked so hard to bring these initiative and implement this initiative. And with this, I will hand it to Imran, who is going to talk about the Zero TB initiatives in the private sector.
Imran, go ahead. I will happily introduce you. Pleased to have you, but please go ahead.
Okay, let me just share the slide set and then we can start. Okay. So just a little bit about Community Health Solutions. It's a sub-recipient for, we have a small glitch. Sorry. Okay, so it's set up as an organization working in public health, and the goal is to sort of reform health markets to improve the current services being provided there for public health priority areas. And our particular focus is TB and a few other disease areas. The issues broadly, and I'm going to go into this a little in more detail in later slides, in the private sector, if I can just sort of summarize here, is the costs. And this is related to a bunch of issues. It's not just about free drugs or consultation costs, but also if you see the last point about fragmented services, then it's about going to your local pharmacy, being unsuccessful, going to your local GP or quack, as we call them here, and then still not being diagnosed, going to a lab, getting testing, getting referred to another site, which is known for TB. So there's a whole sort of patient pathway, which adds costs, both in terms of time and employment, but also in terms of transport and other costs. So, you know, in the private sector, it's surprising, but costs tend to be high, although public sector has its own hidden costs. But also actually the quality of care can be highly variable. And in the case of TB has often been poor. And so, you know, there is this huge opportunity in terms of the private sector serving such a large portion of the population in many of these countries, particularly in South Asia, but also to a large degree in Africa. While that opportunity exists, there are major challenges. And just to summarize a little bit based on these challenges, the model we came up with was to set up sort of customized centers in the 3 major provinces of Pakistan. And we have about 51 centers, which I'll describe in a little bit more detail in a while. And these centers then try and address some of the challenges that I just spoke about, and how we did that or do that, I'll go into next. So some of the more detailed challenges for the search piece of, you know, how to detect more cases. The first one is that, and I'm going to speak here a little bit as if people are familiar with traditional PPM models, although I will also describe that. But while 80% of the population in Pakistan, for example, first seeks care in the private sector, 50% of people actually seek care with less than fully qualified providers, to be generous. So these are not people who are actually qualified doctors, but can be either alternative medicine or informal providers who are not qualified. And one of the challenges with the traditional PPM, or the GP model as it's also known, is that you need qualified doctors because they have to give the treatment. And so one of the challenges that our centers overcome is the ability to get referrals from informal providers, because we provide the treatment ourselves at our centers. And then the other challenge here about the quality of lab diagnostics, and particularly in rural districts, there's a huge challenge. It's largely unregulated. There are a lot of practices which are more about making profits than about actually doing quality testing. And even if there is testing, which is typically AFB smear, Gene Expert is still widely unavailable, and where it is available, the commercial price is often out of reach. And so our centers ensure that we give access both to X-rays, digitized X-rays with CAD4TB currently, or with AI, and Gene Expert to ensure that we are not overdiagnosing. There's an issue of overdiagnosis for clinically diagnosed TB in Pakistan and in many other countries. And so the center sort of addresses that issue through this particular service that we offer. And then there's generally a very low awareness of free TB services amongst the population, particularly that is most at risk, which are lower income. They tend to go look for cough syrups in pharmacies, or look for treatment and antibiotics in private GP or or other private clinics. And that leads to the very long delay in actually being diagnosed and initiated on TB treatment. It's estimated at 110 days. And so, you know, we have, as in the last piece here, we have our own active case finding, but also we have a referral mechanism that gets people in quickly to our centers. And more importantly, the goal here actually is for our centers to become known in communities as being the place where you can get good quality TB treatment for free. And so it's a little bit in Pakistan, for example, and in other countries, there'll be the occasional sort of, you know, service provider. In Pakistan, it's a hospital called Gulab Devi in Lahore, which actually receives something like almost 20,000 TB patients a year. And that is only because of reputation. And so the idea is to sort of make mini Gulab Devis or mini centers of excellence that are renowned for TB treatment so that people know that there are free, high quality TB services available, which in terms of the GP network, people don't really know where and what people are good at. Are they part of an initiative or not, or where to go? And so those were some of the challenges and how we responded to it. I've described verbally, but just to show you a little visual, we have around each center, we have someone we call a medical rep who goes to doctors, but also informal providers around the centers. And now we have almost 100 health providers per center on average, referring presumptive TB patients to our clinics. And they receive a small incentive for this. It's about $3, or actually just under $3. And so there is a referral network that brings patients into our centers. There's also walk-ins. So this is what I was talking about, reputation and word of mouth and communications and campaigns that allow people to know and access high quality TB treatment immediately in the private sector. And then we also have an arm that looks at active case finding. And in this, Hamidah has described in some detail, we operate the same vans in the communities and with our referral network partners to do more active screening in the population with X-rays. And then finally, in addition to our own referral network, we also work with GPs in the traditional GP model and train those GPs and provide and facilitate their lab diagnostics for the search piece. So these are the four major sort of sources of case detection for us: our referral partner networks, our walk-ins, our active case finding, and our GP model network that we're operating. For the treat piece, there's a bunch of challenges. Case holding in the private sector tends to be unincentivized primarily, I'd say. So very often people are reluctant, if they're feeling better, to keep going back to a GP for 6 months or 8 months. And that is both in terms of feeling better, but also there's a cost involved in terms of consultation and going to a GP for the follow-ups. And then in the treat part, there is also the risk of overdiagnosis I spoke about. And the GP model tends to have a high level of clinically diagnosed TB, primarily because they do not have access to gene expert, I'd say, but also then the logistical challenges of making that available is overcome through our centers. We give them that access. And then I mentioned the cost of drugs. It's part of the sort of treatment completion challenge, both in terms of case holding, but also just the catastrophic costs at times for families when they're dealing with treatment and the need to complete it if they're purchasing drugs in the private sector. And then low awareness of need for follow-up smears, and then reporting and linkages to NTP. So in the GP model, these two aspects are covered, but broadly speaking, in the private sector, these services are largely unavailable. And so there needs to be facilitation. And so, as I've mentioned a little bit about our response, this just outlines it and summarizes it. We provide TB treatment at our centers, which are specialized for TB care. They receive counseling, follow-up, and sort of given, we try and assure that they do complete treatment. And we do the same for our patients who are being treated by GPs in the GP model, that we follow up, we provide free drugs to those GPs, and we follow up with those patients to ensure, even if it means going to their homes, to get them to complete treatment to the highest degree possible. And then in the treatment response, there's also the linkage with NTP. We report all the cases through our own centers, most of which are BMUs, what we call BMUs in Pakistan, which means that they're registered as a TB dot center and their data is captured at the NTP level and PPP level. Sorry about that, just 1 second. And then drug-resistant TB management, because we do have access to, sorry, 1 second. Let me just, apologies for that. And then because we do offer Gene Expert, we do also put patients who are RR positive directly through to PMDT sites for MDR treatment, which is another service which has been largely absent in the private sector because of the difficulty of Gene Expert access and diagnosis of MDR or RR positive. Prevention challenges, well, private sector has historically, and even in the GP model so far, at least in Pakistan, not offered preventive therapy. So currently there's frankly no incentive for them to do so, but also implementing it and following it up for people who are healthy and children who are often healthy. It takes a level of convincing and counseling and time, which GPs are often reluctant to give. And so at our centers, because it's dedicated staff, they do the contact tracing, we have the x-rays, they bring in their contacts, and then they also provide the treatment and follow-up. And regarding infection prevention, I mean, at most GP clinics, if they're GP clinics or even informal provider clinics, there's very little, if any, protection for patients in terms of infection prevention currently. And so in terms of the CHS response, we have contact tracing and investigation at our centers, and this is on a pilot basis at only 2 of our centers where we're providing TPT. And we hope to scale up in the next round. Our centers are equipped with UVGI lights, and they're designed, the architecture is designed to allow airflow to go through the centers and prevent infections at the clinic. And then there are other protocols that we follow, such as N95 masks and incineration of biohazard waste, which in the private sector tends to be minimal, if at all present, at most of these smaller clinics and slums. So that's a broad description of what we do. Very quickly looking at the results. So we started scaling up in 2017, and there's sort of a quarterly, more or less steady growth. Currently, for the last 3 months, we have been diagnosing and initiating treatment for over 2,000 patients per month, or we're now at a rate of about 25,000 patients a year through our 51 centers. And we also have a very high B positive rate at our centers of over 55% now, compared to usually under 30% in Pakistan in the GP model. So that's broadly the result. I just want to say that some of this, we also have some work in the Philippines that we've initiated with a very similar model. Some of the sort of situation sort of existing situation analysis is even more alarming. Less than 5% of TB patients diagnosed in the private sector are B positive in the Philippines. And so the need for creating Gene Expert access and dedicated services, treatment completion is completely unmonitored. There's a mandatory notification law and some effort has been put into, but it does not include actually case holding and putting through the treatment completion. And so some of the things that we're seeing here in Pakistan also apply to the Philippines, and we've had some very good early success, which we're hoping to scale up in the next year. And the model itself is a little bit unusual, or at least it's new. The idea of sort of, getting centers in cities that private sector can access, that people know about and can access themselves, and where they can receive high quality TV services at no cost. So, that's broadly in terms of results, just a couple of challenges and lessons learned, and then a last slide after this. So first one is that scale up needs to happen in phases. We went from initially a TV Reach and Unit 8 grant that set up the first 3 centers where we fine-tuned some of these strategies. And we went immediately to 61 centers. And that within 6 months led to a lot of heartache over the next year or two in terms of, the staffing. There was a huge sort of need, I think, to have done this in phases and more slowly. And then I think when we're looking at a referral model, what also becomes important is to consider what the needs are for patients that the referral network is setting who don't have TB. So roughly about 1 out of every 8 or 9 patients that are sent to our centers by our network end up being diagnosed with TB. But that means a vast majority, 7 or 8 out of 8 or 9 patients, do not have TB. And just giving them a CAD for TB score is meaningless. And so I think also helping ensure that we're not exacerbating the patient pathway for other disease areas. And so we've introduced now, to respond to this, proper radiology report that helps them diagnose other issues that the patient, lung health issues the patient may have, and also to check for infection with a basic CBC. So we've added on the needs of our referral network to make this more attractive for them and for the patient's convenience as well. And sometimes I feel, and we've got some hard data on this, so it's not just a feeling, that there's a great sort of, I think, imperative to offer completely free of cost services. And for those of you who are familiar with social marketing, I'd say, even if it's a very highly subsidized fee, having some cost aid allows for incentives to the private sector, be that a distribution margin or a referral incentive or a treatment incentive, as well as ensuring that this can eventually be at par with other private sector costs, so long as they're not catastrophic. And then the need for robust IT and monitoring systems. There's a bunch of issues that come up, and if you have the data, you can analyze it and identify it far earlier and respond to it based on evidence rather than just, guesswork. So I think that was important in this project. We have a bunch of apps in the field as well as in the centers that give us the data to keep refining our service offer, but also how we work with partners. And then, I mean, this is broadly true, I think, of most sort of, projects, is the need to have great coordination with partners, the PTPs, the NTPs, other players in the market, not only to avoid duplication, but also to ensure that it's something which is owned by the public sector in the long run, as we'll talk about in my next slide. That would be the ultimate source of supporting any cost required for private sector services for key public health priority areas. And then, continue innovating with more cost-effective models. I'm going to talk about that in this last slide very quickly. And so as far as sustainability and scale are concerned, on the sustainability or revenue side, we have our donor funding. In the Philippines, there's already a package, which is quite a generous package, although they're trying to actually increase it, which is $70 per TB case, treated in an accredited private TB docs facility. And so our center there is now accredited, and that public funding from the local government, in addition to donor funding, are both, I think, important parts of the financing puzzle for private sector TB work. And then there's local philanthropy and CSR, which we also pursue. And we have somewhat of an innovative piece in our model where We offer other commercial lab diagnostics at a commercial price. It's lower than most of the top competitors, but for quality testing, it's a very low cost, high quality service that we offer through the same centers, and revenue from that goes as cost share. So, between these, I think you can get down to a fairly, and if you look at the other side, fairly competitive cost per case for a very high quality service, which is, diagnosing higher B positive, it's diagnosing RR and MDR cases. It includes some PET initiatives. So we expect in the next 3 years to be down to about $50 per case in the private sector. And we're also looking at ways to lower costs with not just setting up entirely our own centers, but either embedding them in existing facilities where they are non-competitive with the referral network. So what's important is that if you embed it with an existing clinic or hospital, it should not be viewed by a referral network as potentially stealing their patients, which is something we take great care of in our own centers, is to make sure that the referral providers don't feel that we are ending up taking over their patients for other health issues. And then we're also testing currently a franchise model, which goes hand in hand with the lab diagnostics, that we give that business, but operate only the TB desk, which is a much lower cost way of doing the same thing. And so, as I said, continued innovation, ultimately to create better or reform the private sector healthcare for TB. I think there's a lot that can be done. We have some good models already. There's some new ones being tested like this, and which I feel will continue to develop, and we look forward to sort of, collaborating with others in that effort, and we're always available. So that's it from me.
Thank you. Thank you. Thank you both, Hamidah. Thank you, Imran. These were excellent presentation with lots of details. Really pleased to hear your experiences on the ground. I have 3 specific questions and 1 comment. I'm asking the participants who are currently listening, if you have any questions, please use the chat function. If you would like to say something, comment, use the little icon to raise your hand, or let me know in the chat function that you want to comment. Otherwise, I would like to, first question is from Alva Juan, is looking at the algorithmic, asking a specific question about how the AI X-ray, the CAT4TB, has been adopted by the NTP, and whether the testing of infection is also included in that or not. The second question was by Betty, looking at mobilization of the community. How is this done, and how do you pay them, yes or no? And then a question by Guy. What was the case notification in Korangi in 2019? So if either of you has an answer to those questions, Hamidah or Imran, I would like you to maybe talk to these points. And then afterwards, Amir Safdar has raised a few points to me, and I would like to give him the chance to maybe give a short comment of a minute. So who would like to look at these 3 questions that we got?
Perhaps I can go first, and then Imran can add in. Is that okay, Imran? Yeah.
Absolutely, yes. These are yours.
So yes, Betty, you're correct. We do not have IGRA or TST as part of the algorithm for preventive treatment. And that was primarily done to avoid the barriers and adding additional barriers to preventive treatment. A number of our discussions with experts, we had talked in great depth about this. And in the end, it was decided that since this population is going to be under surveillance anyways, if it would be okay for us not to put in IGRA or TST as part of the algorithm. I know that there are other clinical trials and other large implementation projects that are underway through Orem Institute, KNCV, and WHO in collaboration in about 16 countries. And they are also looking at this aspect of whether it should be included or not, and primarily they are leaning towards non-inclusion of TST and EGRAs in the in this algorithm. That's one. The community, and I'm sure Imran can do say more on that. Community camps, there a couple of days before the camps are organized, our health workers go into the community, raise awareness about the camp. They go and speak at the mosques, at the schools with the community leaders, and x-rays, free x-rays are offered. I do not think we pay anything. Imran, do you want to?
Yeah, just very quickly, there is a cost. We don't pay anyone, but when we do these community camps with our partner network, there's a cost of mobilizing. There's some banners and leaflets and stuff, which we give out, as Hamidah was saying prior, and the announcements. And it's really very basic. I think the average cost we have is about $30 per camp. And there are no other incentives per se. Even when the vans go out into the community, there are absolutely no incentives to the community. Our own staff mobilizes people through the various means we've just discussed.
Okay, to the other question of Guy, what was the reporting from Korangi? Guy, I have individual facility reporting numbers. I do not have them all combined. So perhaps offline, we can share that with you, or Imran can share that with you.
Thank you, Hamidah. Amir, I have one follow-up question from Mustafa. He didn't fully understand your explanation on the TST and the IRGAs. I'm wondering whether that can also be taken offline, and maybe we give Amir a comment now. I'll post this question on our discussion web, so we can have a little bit more in-depth description. Maybe Hamidah, you would like to take a moment afterwards online to describe the issue about the infection control. Is that okay?
Absolutely.
Okay. Amir, would you like to make a quick comment? I'm inviting you to say something.
Thanks, Petra, and thanks to Hamidah and Imran for a great insight about their different interventions. We at NTP acknowledge their contribution in the national notification. I have just few comments that despite, unfortunately, in the national notification is not going up. Instead of, for the past 3 years, it remains static. And this year, we are seeing a big decline of 30,000 plus cases have gone down in 2019. However, in rest of the high burden countries, this notification or the presumptive notification is going up. And I do feel that we need to think differently. We have adopted maybe a very innovative approaches of these partners and their contribution, but I need to for the next funding cycle, because they are also aware that Pakistan is facing a big challenge of funding contribution from the national or the provincial TB control programs. How we need to strengthen the current existing models or to expand to the more rural areas and to engage lady health worker communities, more visibility towards the TB control. I would like to appreciate if they can add into these things. And I'm thankful to their contribution, and we are looking forward at NTP to be the partners instead of the and contributing towards the national notification. Incident should be going down, and we are not making enough efforts that national notification, it is decreasing at a very slow pace, unfortunately.
Maybe I can answer a bit, sorry if that's okay. And then Hamidah, if you'd like to add. So I think it is really important, as I was saying earlier, to look at the data and analyze it, in detail, because when you get granular, you find, I think, important clues. And Amir, thank you for your support and for your appreciation. I think if we look at the data, almost the entire decline, if not more than this decline, came from the Punjab, where there's very little activity by this particular range of activities. And what happened in Punjab, I'm not going to go into it too much, but I can definitely say that the decline is in districts where we don't work at all. So I think that's important to consider, but I also completely agree that it is time to review what is working. How can we increase rural coverage, as you just said? And I think, in fact, the Punjab PPP has come up with some excellent ideas. It is primarily about mobilization and getting people out there into rural areas. And they have asked private sector implementers to get involved in putting more people in those districts to reach out at the tehsil level. And I completely agree with that strategy, that you need to mobilize in rural areas more effectively. And there are other ideas, as you mentioned, LHW program, and also the need to look at, where we want to invest and how much. And I think those decisions for the next round, as you say, will be important. And we look forward to guidance from the NTP on this and the PTPs.
Thank you, Imran. Hamidah, so we are actually at our time. It is 1 hour. It's the end of our hour. I have 2 more specific questions, which I will keep. I will post these questions on the forum, and I would like to ask Hamidah and Imran to look at the forum. I will prompt you when it is all online. Any participants, if you have any more questions, please feel free to send them to me or to post them directly on our website. I would really like to thank Hamidah and Imran both for their in-depth, detailed presentations. We are going to post the presentations plus this full webinar on our site. So anyone who has not been able to join us today, or those who would like to see the presentations webinar again, you can find all the information on our site, tbppm.org. I would like to wish everyone a happy rest of the evening. Thank you for joining us. Thank you for great questions to start the discussion, and I'm looking forward to taking the discussion forward online. I'm wishing everyone also who is around here a successful World TB Day. I know that you in your organizations must be somehow working on some campaign events. And we are working on several next webinars. There are going to be webinars posted soon on our website. We have about 4 or 5 webinars lined up, and we're very excited to share them with you. So please keep looking out. Thank you for joining us. And we look forward to hearing from you and exchanging with you more on our site. Wishing everyone a happy evening, happy day, and till the next time.
Thank you, Petra.
Thank you.
Thanks, Imran and Hamidah. This is Madhu. Thank you so much.
Thank you.